Hi, it's me, Ingrid P. And I'm going to talk a little bit about why I did not choose to go and work in psychiatry, and why, I'm a GP doctor rather than a psychiatrist, and I'm a newly diagnosed autistic person, so I've been part of the mental health care. I've only talked to a psychiatrist once as a patient, and that was during my diagnostic process. But I've worked with several psychiatrists, and I worked 3 months during my residency. I worked 2 months before my internship and 3 months during my internship. So yeah, and then during medical school I was also there for a semester, so a few months. So I've done not much psychiatry work, but a little bit less than a year total. And so I've seen different psych wards, and yeah, so it's not for me. Even though I am very, very interested in psychology, psychiatry is another thing. I am happy with not becoming a psychiatrist, though I do sometimes wish that I was a psychiatrist so that I could be an autistic psychiatrist who could diagnose patients with autism and ADHD. That would be like a perfect job for me. But the fact is that the rest, like the psychiatry ward, the wards, and a lot of the outpatient work as well is just not for me. And this video might be a little bit anti-psychiatry, in that I am very critical of a lot of things that happen in psychiatry. However, I don't want to be too negative, because I do think that people need psychiatric help, and I do want people to seek that help if they need it. I myself I've tried escitalopram, Cipralex, when I was around 20, 22, I don't know. And I got really bad side effects with heart palpitations. And I went actually to the ER, and they told me it was nothing. But yeah, I stopped taking it after that. And also then I took sertraline when I went into my burnout 2 years ago. It's not a medication for burnout, but my burnout led to me being depressed. So it was curing that, it was helping with the depression. I also got a lot of side effects from that. My mouth was very dry. I had dizziness if I forgot to take the medication one day. I had troubles with peeing, because there's serotonin all over the place in the body. I got more anxiety at the start, and I was easily irritated during the whole process. I also did not feel emotions very deeply, and I had trouble sleeping. So I had a lot of problems with it, but I kept up with it because it did actually alleviate some of the weight that I was carrying for a little while. Then after a year of taking it, so last summer, I decided to lower the dosage, and I decided to just stop with it completely. Now, I don't recommend you do that. You should talk to your doctor first. I just knew that I had regular phone calls with my doctor, so I could tell her if anything was going wrong. I also do happen to be a doctor, so obviously I'm a little bit hypocritical in that sense, in that I will sometimes do things that I do not recommend my patients doing. Because, yeah, you shouldn't treat yourself, but I wasn't the one who was prescribing this medication to myself, so I think that I had enough separation from my own treatment that it was okay. But it might just be an excuse for myself, I don't know. Anyway, With all that out of the way, first of all, I want to say that psychiatry has no understanding of autism in general. When I've gone to the psych wards to talk to people, talk to psychiatrists or residents in psychiatry, or nurses, they just don't understand autism. One doctor actually said to me that, oh, so these are the diagnostic criteria for bipolar, these are the diagnostic criteria for psychosis. And if you have autism, nothing makes sense. And he was like laughing while saying that. And I was laughing too because, I just went to fit in here. I'm masking. But on one hand, it is true that autism makes at our diagnosis, the neurodivergence makes the symptoms of different diagnoses look different than the school book example, because like a lot of autistic traits can look like OCD, a lot of autistic traits can look like bipolar. So that is a positive, but the negative is that like it seems like nobody is willing to go into that can of worms and explore what is autism and how does it affect these different conditions. They're just like, well, nothing makes sense, and they are happy not knowing more, and that is problematic. So now that I know that I'm autistic, I'm like, oh wow, that's a reason for a lot of problems in the psychiatry, is this lack of understanding of autism. Because I think a lot of the people in psychiatric patients are, autistic or ADHD or both. I'm not going to say neurodivergent because basically anyone in the psych ward is neurodivergent in some sense. If a neurotypical is there, it's because of some big crisis and probably not because of some psychiatric underlying problem in most cases. I think it's quite rare for somebody who is neurotypical to end up in the psych ward. But anyway, we've got that. Then there's the BPD, borderline personality or buttered potato disorder or whatever. I'm not sure if that diagnosis even exists because I think that it's basically PTSD in women, or often combined with autism, because the presentation of PTSD might look different. And yeah, nobody with BPD is like, everybody with BPD has some kind of really bad trauma. That's kind of what I've seen. And like, these things go together. Like, PTSD is always a part of BPD. So I don't think that exists, but unfortunately there's such a stigma around BPD that, and why is it always girls? There's such a stigma around BPD, and I know that psychiatrists look at it and they're like, oh, BPD. They're like, let's not take this person seriously at all. And let's say that everything that they do is for attention. And yeah, sometimes it is for attention, but that's because they only get this bad attention from the psychiatrists. But yes, they're traumatized. And I hate that whole aspect of like not taking people seriously because of their diagnosis. So I couldn't really get my head around that, and I did not like it. So that's a reason why I'm not in psychiatry. Another one is, capitalism messes us all up. And also it's kind of hard sometimes where poverty begins and where psychiatry begins. I think that stress due to economic difficulties can trigger psychiatric difficulties, like for example, psychosis. The different stresses on your brain can be triggered by poverty, but also psychiatric difficulties such as psychosis or bipolar can lead to you not being able to work in the capacity, and so you will become poor due to that. And sometimes it's hard to separate one from the other, and as a psychiatrist you can't do anything about the poverty part. And it seems like, and the poverty part and the mental health, and then there's the whole, like, you don't have a social network of friends, or the social network of friends that you have also have a bunch of problems, and you know, you might end up in the crowds that is into drugs, and then you add that to the mix, and that also worsens the poverty, and it also worsens the mental health, and all of that all together all the time. I'm not cut out for dealing with that, because I already find myself quite helpless in helping people when it's general practice, which is like very light mental health difficulties. But yeah, there's such misery. There's so much poverty, and I can't help any of that. I can't, you know, it's my job is taking care of like the medicines, I guess, and it's not very fulfilling. You know, it just feels like, you know, I should be working on the social part of it as like an advocate rather than like as a doctor. And you know, everybody feels awful right now. You know, capitalism makes us all feel awful. It's just that it affects people who are already at risk even more. So that is truly dismal. It's truly awful, and I can't really deal with that. Another thing is that it feels like the psych ward, like the job of the doctor is to put people into boxes of normal and not normal, and dehumanizing people in the process, and also the fact that a lot of the psychiatrist's work, it's not the psychologist, it's not the same, is not about actually treating, you know, healing a person psychologically. A whole thing of being a psychiatrist is to decide if a person should be locked into the hospital or not, if the person is allowed to go on walks with the staff, to decide if a person is well enough to leave the hospital or not, and determine the effects of the medication. And it seems really dehumanizing and normatizing, and yeah, it's I don't like it. There isn't much to do in the wards except for be stressed by the other people in the ward. So if I were put into a mental health hospital, I think that I would get out more stressed than I was when I came in. Because the noise and the other patients do crazy stuff, and I'm using crazy as like, you know, a lot of people object to the use of the word crazy. I don't have another way to describe that, but I'm just saying, like, if people start stealing your stuff when you're at the mental health place, or they start shouting in your face, like I've noticed all sorts of things, or they start to watch you while you're sleeping, like I've gotten all sorts of different accounts of people. It's like, this isn't a safe place, you know? And I think that as an autistic person, I would just not want to leave my room, which would be as a sign of like not cooperation, which, you know, sounds a little bit like prison, you know, everything is monitored. You're monitored for acting neurotypically. And so a lot of times the staff will be like, oh, he didn't want to eat and he didn't want to leave his room, so we got him out. And so we don't think that the medication is working because he's all depressed. And it's like, it's not always depression. Sometimes it is the sane thing to want to stay in your room where it is safe rather than going outside and socializing with people who might be not nice to you, you know? And also sometimes the food is bad, you know? There are problems, and you can't expect people to just go into a box. Also, there's a problem of like there's nothing to do in the wards, so obviously like going out to eat is like very important because there's nothing else going on. Sometimes there's like, you know, a radio or a TV or something, or there might be some books to look at, or yeah, there might be like a common room where you can play board games or something. But I thought before ever visiting a psych ward that there would be like therapy. I don't know how it is in the US. Maybe it's better in the US. But I did find out now that in the US, if you go into the psych ward, a lot of places like will give you a paper gown. Like that's dehumanizing and humiliating to the extreme. In the psych ward in Sweden, you get like hospital clothes, but you can wear your regular clothes as well, if they're not too tattered or whatever. But yeah, it's dehumanizing, you know? It's already awful being in a hospital, but being in a mental health hospital is like really bad. And so I thought that there would be more like a therapist that you could meet while you were in the psych ward. No, there is no therapist. Sometimes you can get one, but yeah, it's not the norm. So when you're there, you're just supposed to just like hang out and sleep, which seems like impossible. I don't know how anybody can sleep in a psych ward. Well, if you're sedated with a bunch of medication, then maybe. And yeah, so a part of being a psychiatrist is basically sedating people, which also does not sit right with me. I know that is the treatment for a lot of problems like acute psychosis or acute alcohol, you know, or a lot of drug overdoses and stuff like that. Or overdoses, I mean, you know, like acute aggression is often treated with sedatives. But yeah, does not sit really right with me. Another thing is that, so I'm keeping people alive against their will. Now, I don't want people to die. I don't want people to kill themselves. But it just seems wrong that I would have the power over another person deciding what they want to do with their life. Because like when I'm in general practice, I can propose all sorts of treatments and stuff, but it's not my problem if the person then leaves and does not follow my recommendations. It's their responsibility, you know? It might be frustrating for me, but it's like, it's fine, you know? I'm not going to say, I told you so, you know? Like, if the person comes back and is asking for help again, I'm going to, you know, help them with the ways I can, but I am not forcing anybody to do anything. But here in psychiatry, you're kind of forcing people to do things in the psych ward. Now, in the outpatient ward, you might not be forcing people, and a lot of times the people won't take their medication, and then they would end up in the acute psych ward. And yeah, I can't deal with that thought. Another thing is that when you're in the psych ward, you rarely have time with the doctor, like actually discussing your treatment. Often you'll maybe meet the doctor like once every 2 or 3 days. Sometimes I won't meet the patient for a whole week because they're just like, okay, status quo, nothing's happening. And yeah, I understand why patients would want to meet their doctor if they're in a facility that is not their home, you know? And yeah, it's sad to see, you know, like people begging to be let home. And then there are those who are scared of going back home, like, you know, because they're scared of how they'll manage on their own. So yeah, I don't really like that. I wish that there was some other kind of possibilities of things to do in the psych ward, because at the moment it's quite dismal. The other thing is, like, I am a woman and I am, you know, I don't want to be, you know, there's a lot of violence that could happen. And I don't like feeling unsafe. And I know that a lot of people have, you know, found ways to, you know, deal with this situation, but for me, I can't deal with this constant threat of being hit by a patient, or being, you know, things thrown at me as, you know, as a doctor. I cannot deal with that. And I know that it's not always the person's fault because, you know, they're in a different state of mind. But yeah, I can't do it. So kudos to those doctors who can. I just can't deal with the constant threat of something going wrong and the violence that might ensue. So that's a reason why I did not choose psychiatry. Another thing is big pharma. Okay, I'm not against big pharma because, you know, I work as a doctor and I prescribe medications all the time. But sometimes it just feels like, you know, it's the social stuff that is causing the problem and no medication in the world will help, you know. And yeah, a lot of these medications cost a lot of money. And it's kind of like I've noticed that a lot of medications, people stay on them for years and years and years. I've seen patients who've had the same Cipralex for 15 years. Like, at what point are we going to decide to choose to stop taking it? It's really scary, you know, like, oh, this person has been fine for 15 years. When is it okay for me to say, no, let's try not being with them? Because it might make the patient worse. And I'm trying to work with this because I have patients who have that exact thing. And I should be less scared of, like, taking those medications away and testing out how it's going to be. But it is scary to think, like, oh, maybe this person will suddenly start experiencing a lot more anxiety and depressive symptoms. And it seems like a lot of psychiatry do not think about taking away those medications. They're just like, okay, well, now you're on this. Don't stop without telling us, basically. When really, sometimes it would be nice to, like, think it again, you know, be less scared of being without certain medications. Now, also, some psychiatrists are very weird, and being weird is a thing, it's fine, but sometimes it's a little bit hypocritical and a little bit like, I'm concerned about how do you treat your patients, because one of these psychiatrists actually took cocaine quite often at parties, which at first I thought I was joking, but actually he was, and the staff were in at these parties, and they were just like laughing it off, like, oh yeah. And I was like, okay, but like, is the dealer the same dealer as the patient's dealer? And also, how are you telling people to stop taking drugs if you're taking drugs? It's like, I'm not saying that we all have to be perfect beings, but it's just like, yeah, maybe, practice what you preach a little bit. So that kind of put me off. Another doctor microdosed lithium because he thought that it was good for the brain. And it's like, yeah, but he didn't even have bipolar disorder. So microdosing on lithium is probably more of a problematic thing. And this guy was my supervisor at psychiatry at one point. So yeah, I couldn't really take him any seriously. And yeah, the way that they talk about patients sometimes, I'm like, I'm glad I'm just working with you and not like actually a patient of yours. There was this other time where I've told you guys about this once, where about a year ago, there was a patient who was experiencing, like, he thought that everybody at his gym were talking about him behind his back. The thing is, he lived in a pretty small town where that is a possibility, and I was told by the psychiatrist to put him on risperidone, which is an antipsychotic medicine. And I was like, yeah, but this might be true. And he was like, yeah, no, but the way that you describe it doesn't seem like it's a healthy perspective to take. And I don't know. I don't think that he was experiencing like actual psychosis that was harmful. Like, true, he was experiencing a difficult situation, but I think it is very possibly true that he might have rumors said about him in this gym in this small town. Like, that is something that happens. I mean, I've been a victim of rumors being spread about me and people thinking that I was crazy for implying such a thing. And yeah, it's kind of like this normative way of being, like this idea of like, this is the normal way of experiencing things, and anything out of that is pathological, is very dehumanizing. And it's also an easy way to get misdiagnosis, A lot of BPD diagnoses, are actually, describing just a difficult person to be around, basically. And yeah, the way that symptoms are interpreted, I'm not comfortable with that. Another thing is that queerness is not seen as a normal thing. I mean, I think that a lot of healthcare has problems with this. And I mean, I live in Sweden where things are progressive for queer people and stuff. But I think that it's seen as a sign of deviance in a way. And deviance is pathological. And, that goes quickly into like, oh, so this person is queer because they're autistic. Or they're queer because they are borderline. And a lot of psychiatrists, I don't think that they're like quite aware of what they're doing. But yeah, so I'm very careful about disclosing that I'm queer with psychologists because it could easily be pathologized against me. Also, like, I describe certain things in certain ways that are interpreted differently. I've told you guys once about the fact that there was a period of my life where, I didn't want to kill myself, but I didn't want to, live. So I said I wanted to be a cat. was basically what I said to my psychologist. And my psychologist thought that I was actively suicidal and that it was wrong and that I needed to be put on antidepressants. That was why actually I got put on antidepressants in the end, because I said I wanted to be a cat, because cats have a much more chill life than what I have. Which, that's not the way of diagnosing somebody with suicidality, but I made a video about that, so I'm not going to go more into that now. But so yeah, I've gone through all of my points. So there's a lot of things that I do not vibe with. So one of them is the dehumanization of people. One of them is the medicalization of everything that it falls outside of the norm. The other one is no understanding of autism, and also the fact that there's the psych ward system really needs to be changed completely from the ground up. And then the hypocritical nature of psychiatrists, and like what is even a medical diagnosis, and what is just different pressures from medical community or from big pharma or whatever. And also this kind of power that psychiatrists have over people that doesn't sit right with me. So there's all that. And then there's also the cultural differences. Like, I rarely see somebody who is not white go to the psychiatrist, and that leads to problems in our idea of psychiatry. We don't know really how to treat people, and our treatment should be more integrated into, like, the social network that you have and all that. I think that the whole system really needs to be changed from the ground up. I don't really know how. I haven't really thought about solutions. I just know that it's bad. It's bad. And I'm talking about Sweden, which is probably much better than a lot of countries. But I think we need to, this medical way of doing things, I think that we should have more like preventative measures before getting to this point of like acute suicidality. And one of them is access to therapy. There is no access. At this point, like, the waiting lists are 3 months long, and unless you want to go to private therapy, and private therapy costs like, hundreds of dollars, is not adapted to each kind of person. There's often like a standardization that happens, which I don't like. Another thing is doctors prescribing too much medication because that's the only thing that they can do, right? And then the fact of like society, needing to protect its most vulnerable people, with help, financially, or with finding a job, or with getting accommodations at a job, or creating groups where people, like-minded people, can become friends and have a better social network, a better community. So that's all I had to say. There are probably other things. I just felt that this video has been long in the coming. I've thought about this for several years now, actually from the start of my channel, and I felt I needed to create at least this draft. I don't think that this is my final thoughts on the subject. I'll probably develop more and more the more I, get better in my own and mental health. But also as I get more and more experience as a doctor, I might change views on this. I know that I've already changed views on this since medical school, and also since getting my autism diagnosis. So tell me what you guys think. Have a great day.